Welcome to The Deep Dive, the show where we cut through the noise and get straight to the insights you need to be truly well informed.
Mm.
Today, we're diving into a topic that touches so many lives at their most, well, vulnerable and transformative moments: medicines in pregnancy and breastfeeding.
Yeah, it's a big one.
If you've ever found yourself navigating that maze of what ifs when it comes to medication during these periods, maybe you're managing a long-term condition or facing a new diagnosis, or even just wondering about, an everyday over-the-counter remedy, then this deep dive is definitely crafted for you.
Absolutely.
Yeah.
It's an area where the advice can often feel, well, contradictory, can it?
Yeah.
And the uncertainty can be pretty overwhelming.
Right.
So our mission today is really to equip you with clear, evidence-based knowledge. We've drawn this from a really comprehensive lecture on the subject. We'll try to unravel why medications are taken, how drugs actually behave in these really unique physiological states, what the true risks involved are, and maybe most importantly, how informed decisions can actually be made for the health of both the parent and the baby.
Sounds good.
Yeah, prepare for some hopefully insightful moments that might just reshape how you think about medicine in these contexts.
Okay, let's open the curtain then, starting with pregnancy itself. You might wonder, why are pregnant individuals even taking medication? Is it often for things they were already managing, pre-existing conditions?
Absolutely. Yeah, many people embark on pregnancy already navigating chronic conditions like hypertension, diabetes, asthma, epilepsy, or even depression.
Right.
And these frequently require ongoing medication because stopping them, well, that could pose an even greater risk to both the mother and the baby.
Okay, that makes sense. And beyond those pre-existing conditions, pregnancy itself brings about such, well, profound hormonal and physiological changes. Can those changes actually lead to new conditions that need medication?
They certainly can, yeah. Think
Yeah.
about the common experiences like morning sickness,
Mm-hmm.
which, if lifestyle changes aren't enough, might indeed need medication, or things like reflux and constipation,
Yeah.
often worsened by the hormonal relaxation of smooth muscles throughout the body.
Ah, okay.
But it's not just those sort of nuisance issues. More serious conditions can develop too. Gestational diabetes, for instance,
Mm-hmm.
caused by pregnancy hormones leading to insulin resistance,
Right.
or deep vein thrombosis, DVT, that can occur due to hormonal shifts, and gestational hypertension, which can unfortunately progress to preeclampsia. Serious stuff.
And what about the immune system? That changes too, doesn't it? It's naturally suppressed.
That's right. The immune system is sort of dialed down
Mhm.
to prevent the mother's body from rejecting the fetus, which is,
Mm.
amazing when you think about it.
Yeah.
But it also makes pregnant individuals more susceptible to acute illnesses, things like coughs, colds, influenza.
Which is why vaccination is so key.
Exactly, especially for flu and pertussis. It's so incredibly important at any stage of pregnancy every year. And those hormonal changes also increase the likelihood of infections like UTIs and vaginal thrush.
And of course, there's labor itself, pain relief, anesthesia, often needed.
Yeah.
But beyond those sort of direct medical needs, some choices are more about lifestyle, right? Like smoking cessation. I know in New Zealand, something like 10 to 15% of pregnant women are smokers.
Yeah, that's right.
They might seek help to quit. And here's something that often surprises people. Recent studies have found no evidence that babies whose mothers took medication for smoking cessation, things like NRT, varenicline, bupropion, had higher rates of major birth defects compared to those whose mothers didn't use any intervention.
That's a truly powerful piece of evidence, isn't it?
It really is.
It allows for incredibly important informed decisions. It really reframes that whole conversation around balancing risks and benefits.
Yeah.
And
Cool.
speaking of informed decisions, a huge gray area exists because, well, over half of all pregnancies are unplanned.
Wow, over half.
Yeah, which means individuals might be taking medications without even realizing they're pregnant.
That's a huge point. And it leads me to wonder, are most medications even approved for use in pregnancy? Or is it? It's
Yeah.
more observational.
That's a crucial point. And it's truly fascinating and perhaps surprising to many that most medications used in pregnancy are actually considered off-label.
Off-label, okay.
Yeah, or unapproved for this specific use. And the reason is pregnant individuals are largely excluded from clinical trials, for ethical and legal reasons.
Right.
So much of our understanding comes from observational data, from real-world outcomes, rather than those direct controlled studies.
So connecting that to the bigger picture, it explains why the guidance can sometimes feel a bit less definitive than we'd like.
Exactly. And if we look at current trends, studies from places like New Zealand show a clear increase over a 10-year period in both exposure to prescription medicines and just the sheer number of different medications dispensed during pregnancy.
Any particular types stand out?
Yeah, the most common prescriptions are antibiotics, then analgesics, pain relief, and anti-nausea medications.
Okay.
But here's a truly, well, alarming statistic. A recent international study found New Zealand ranks alarmingly high, third globally, after the U.S. and Iceland in opioid use during pregnancy. Nearly 8% of pregnancies exposed.
8%.
Huh.
Wow. That opioid statistic is truly alarming, and it underscores a fundamental question. How did these drugs even reach the baby? How does the drug get across that placental barrier?
Right. That's where the incredible complexity of the placenta comes in. It's this sophisticated interface where maternal and fetal blood come into very close contact.
Mm-hmm.
But they typically don't mix. They're separated by this thin placental membrane. So medication passes from the mother's blood through this membrane and into the fetal circulation.
Okay, so how does that transfer actually happen? Are there different ways it works?
Yeah, there are four main ways drugs make that journey. The most common is passive diffusion. Think of drugs like paracetamol. They just move from a higher concentration in the mother's blood to a lower concentration in the fetus's blood. Like sugar dissolving in water, basically.
Simple enough. What else?
Then there's facilitated transport. This uses carrier proteins to help drugs cross, but it doesn't require any extra energy. Sort of like a revolving door.
Okay, like a helper molecule.
Exactly. Then number 3 is active transport. This is like a tiny pump. It needs energy, ATP, to move drugs, sometimes even uphill against a concentration gradient. Digoxin's an example there.
Energy required. Got it. And the last one?
The last one is endocytosis. This is for really large molecules, like the maternal IgG antibodies that transfer when a mother gets, say, a pertussis or whooping cough vaccination.
Ah.
These antibodies are essentially swallowed by the placental cells and then released into the fetal circulation. And that provides passive immunity to the baby for their first few months of life. It's pretty clever.
That's amazing. So it means drugs given to the mother aren't just sort of incidental exposure for the baby. They can actually be used to treat the baby directly.
Absolutely. And it's one of the most remarkable applications of this understanding. I remember a case involving preterm twins where the mother received corticosteroids.
Mm-hmm.
The difference it made was just palpable. These tiny babies, born so early, showed remarkably mature lung development, needed minimal respiratory support.
Wow.
It's moments like that you really see the targeted power of medicine even across the placental barrier. And even some cardiac drugs can be given to the mother to control a fetal heart condition.
That's truly incredible, the placenta as a medical delivery system. So what factors then influence how easily a drug crosses this barrier? What makes one drug cross easily and another not?
Several physicochemical properties are key. First, the concentration gradient. Usually, the higher the drug concentration in the mother's blood, the more will transfer.
Makes sense.
Second, molecular size. Think of it this way. The smaller the molecule, like alcohol, the easier it slips through.
Okay.
Larger molecules, like heparin or insulin, they generally can't make the journey. They're just too big.
And protein binding. That sounds important.
It absolutely is. Only the unbound or free portion of a drug can actually cross the placenta.
Ah, okay.
So if a drug is highly protein-bound, it tends to get sort of trapped in the maternal plasma, meaning less reaches the baby.
Right.
Lipid solubility also plays a role. Fat-soluble molecules diffuse across membranes much more easily. And finally, there's the drug's charge, or its degree of ionization. Basically, drugs that are uncharged or unionized slip through membranes more easily than charged ones.
Okay, so lots of different factors. And the mother's body is changing so dramatically during pregnancy. How do those physiological shifts specifically affect how drugs behave? You know, ADME absorption, distribution, metabolism, excretion.
Yeah, these changes are really profound. For absorption, reduced gastric motility that's down to progesterone can slow down how quickly a drug starts working.
Okay.
Changes in stomach pH and blood flow can also alter absorption rates. For distribution, there's a significant increase in the mother's cardiac output and plasma volume, nearly 50% by week 20.
50%. Wow.
Yeah, and total body water increases too. This increases the drug's volume of distribution, essentially diluting it more.
But at the same time, doesn't plasma protein binding decrease, which means more of the drug is free and active?
Precisely. Yeah, exactly right. For metabolism, the liver, the body's main drug processing plant, ramps up or slows down certain enzymes, the little workers that break down medication.
Any examples?
Sure, a concrete one is methadone. Pregnant individuals on opioid substitution therapy often need increased doses and split doses as pregnancy progresses because their body is metabolizing the drug much faster.
Right, okay. So the body's just clearing it quicker.
Exactly. And what about getting rid of drugs? Excretion is also significantly affected. Renal blood flow and the glomerular filtration rate, GFR, increase dramatically by 20 weeks.
So the kidneys are working harder.
Much harder. This leads to much faster elimination of drugs cleared by the kidneys, like digoxin, for example.
So what's the big takeaway from all these bodily shifts? What does it mean practically?
It's simple but profound, really. Your body is a completely different landscape during pregnancy. A dose that worked perfectly before might now be totally ineffective or even dangerous, all because your body is working differently, often working overtime.
Yeah.
It just underscores why your usual dose rarely applies.
Yeah.
Constant medical oversight is absolutely indispensable.
Okay. This brings us to a really critical and often frightening aspect, the risks of drug-induced birth defects or teratogenicity. It's important to set a baseline, though, right? Even in healthy pregnancies with no drug exposure, there's still a background risk of, what, 2–3% for birth defects?
It's correct, yeah, 2–3%. So drug exposure is one controllable cause, but it's definitely not the only factor.
Right.
And you really can't discuss teratogenicity without mentioning the profound tragedy of thalidomide back in the 1950s.
Yes, thalidomide.
This drug, used for morning sickness, turned out to be a potent human teratogen. It caused severe limb deformities, phocomelia, where limbs are underdeveloped or missing. And this happened despite showing no such effects in animal trials beforehand. It was a tragic lesson that powerfully underscores the unique and sometimes unpredictable susceptibility of human embryonic development.
So teratogenic medicines interfere with normal embryonic or fetal development, leading to these congenital anomalies. But it's important to understand that teratogens don't always cause harm, do they? It's not guaranteed.
That's a crucial point. No, it's not guaranteed. Susceptibility depends on several things: the drug's dose, the duration of exposure, and critically, the timing of that exposure relative to the embryo's developmental stage.
Timing is key.
Absolutely key. And a drug doesn't even need to cross the placenta to cause harm. It could, for example, constrict placental blood flow, cause issues that way.
Okay, so let's break down those phases of human development and the associated risks. What are the critical windows we need to know about?
Right. So the first 2 weeks after conception is the pre-embryonic period. It's often called the all or none phase.
All or none.
Yeah. Drug exposure here usually results in either embryonic death, leading to a spontaneous abortion, or basically no effect at all.
Okay.
Then comes the really critical time, the embryonic period, from weeks 3 to 8. This is the period of greatest risk for structural malformations because all the major organs, brain, spinal cord, limbs are rapidly forming.
Weeks 3 to 8. Got it. And after that, once the main structures are sort of laid down?
From week 9 right through to term, we're in the fetal period. Now, major structural defects are less likely, but organs like the brain and kidneys are still developing and maturing.
So still vulnerable.
So vulnerable, yes. Medications primarily affect functional development during this time. So things like causing hearing impairment or loss. They can also have long-term effects manifesting later in life, intellectual or behavioral adverse effects, for example.
And right at the end?
And in late pregnancy or during labor, medication can also affect the neonate after delivery, potentially causing things like withdrawal symptoms.
So we're talking about two main types of anomalies: structural, like cleft lip, cleft palate, spina bifida. And a crucial note here, folic acid supplementation can prevent spina bifida in up to 70% of cases, right?
That's right, a huge impact.
And then there are functional or developmental defects. Can you give us some concrete examples of drugs known to be human teratogens?
Certainly. The list includes, obviously, thalidomide, also ACE inhibitors and angiotensin II, receptor antagonists, common blood pressure meds that can cause fetal kidney problems,
Right.
certain antiepileptics like sodium valproate. You might have seen that common symbol on the packaging, the pregnant woman with a cross.
Yes, I have. It's quite striking.
It is a very clear warning. And there's actually new, very recent research about sodium valproate.
Oh, really? What's that?
Well, it suggests neurodevelopmental risks in children if it's taken by men around the time of conception, not just women.
By men. Wow.
Yeah, it's prompted a shift in advice. Contraception is now recommended for male partners on this medication for at least 3 months after they stop taking it.
That's a significant update. What else is on the list?
Other known teratogens include isotretinoin, which is used for severe acne, warfarin, methotrexate, lithium, and live vaccines like MMR. They're generally contraindicated during pregnancy.
Okay. This all brings us back to that critical balance, doesn't it? Balancing the potential risks to the developing baby with the therapeutic benefits of the drug to the mother, it's not always about avoiding drugs entirely.
Absolutely not. For many chronic conditions, not taking necessary medication can sometimes be far more detrimental to both the mother and the baby than taking it.
Right.
It's a complex, highly individualized decision. It really requires careful consideration by the healthcare team and, crucially, the patient themselves.
So given all this complexity and how things keep changing, how do healthcare professionals and, our listeners stay updated and find reliable information?
That's a great question. There are several trusted, evidence-based resources. For healthcare professionals, Briggs Drugs in Pregnancy and Lactation is a standard. There's the Women's Pregnancy and Breastfeeding Medicines Guide from Australia, the UK Teratology Information Service, UKTS, and Medicines Information Centers, usually found in hospitals.
Plans for the public?
BMPS, that's Best Use of Medicines in Pregnancy, is an excellent UK-based resource for the public. MedSafe here in NZ also has info.
And a really important caution you mentioned, don't rely solely on those simple letter categories like Australia's A, B, C, X system.
Definitely not. They can be overly simplistic, sometimes misleading. You really need to read the full summary, understand the context and the nuances.
As the information evolves.
Constantly. The importance of continuous updates just cannot be overstated. And it often surprises people how guidance for even common medications can change. Take ondansetron, for example.
Often used for morning sickness.
Exactly. Widely used before 2020. But post-June 2020 updates showed a small increased risk of oral cleft defects with first trimester exposure.
Small, but significant enough to change practice.
Yes. It now requires specific, informed consent before prescribing it in the first trimester.
That's a big shift for such a common drug. What about everyday, over-the-counter stuff we might not think twice about?
Another compelling example. NSAIDs like ibuprofen.
Right, everyone has those.
Their guidance was updated in 2022. They are now contraindicated, meaning shouldn't be used, in the third trimester,
Why is that?
due to risks of low amniotic fluid and, more seriously, the premature closing of the ductus arteriosus. That's a crucial blood vessel in the baby's heart that needs to stay open during pregnancy but close naturally after birth.
And if it closes too early?
It can lead to serious heart and lung complications like pulmonary hypertension or even fetal heart failure. NSAI should also ideally be avoided in the first 2 trimesters if possible.
Wow, that really shows that even common, easily available drugs need careful consideration.
Absolutely.
So let's try and distill all of this into some general principles for medicine use during pregnancy. What are the absolute key takeaways?
Okay. First, avoid medication use if possible, especially in that critical first trimester.
Right.
Second, only use it when the benefit to the mother clearly outweighs the potential risk to the fetus. And that needs evaluating case by case.
Makes sense.
Third, prefer therapeutically effective medicines that have a long-established safety profile. Try to avoid brand new drugs or using multiple medications polypharmacy if you can.
And always the lowest dose that works for the shortest time needed.
Exactly. Lowest effective dose, shortest necessary time. And crucially, fully inform the patient of the possible risks and involve them deeply in the treatment decisions. This is so vital, especially since, as we said, much medication use in pregnancy is technically off-label.
All of this just highlights how critical proactive prenatal care really is.
Absolutely. Prenatal care is all about improving pregnancy outcomes by identifying and modifying risk factors before they become major problems.
Like managing chronic conditions.
Yes. Getting specialist referrals to manage chronic illnesses, maybe changing antiepileptics before conception if possible. It also involves screening for infections, making sure cervical smears are up to date, and confirming vaccinations are current.
Like flu and whooping cough.
Exactly.
Yeah.
Influenza and pertussis, or whooping cough. The pertussis vaccine is typically given from 16 weeks during pregnancy, specifically to protect the newborn in those first vulnerable months.
And nutrition plays a big part too, doesn't it? We mentioned folic acid earlier.
That's fundamental.
Yeah.
Adequate folic acid is essential, ideally starting at least 1 month before conception and continuing for the first 3 months.
And sometimes a higher dose is needed?
Yes, a higher 5 milligram dose is often recommended for high-risk individuals, those with a family history of neural tube defects, or people on certain antiepileptics, those with diabetes or obesity. Iodine is also really important for the baby's thyroid and brain development.
Right.
And naturally, prenatal care reinforces all the standard advice. Avoid non-essential drugs, tobacco, alcohol, and any substance use.
Okay, that covers pregnancy thoroughly. Now let's shift gears to part 2. Medicines in breastfeeding. Breastfeeding is so widely encouraged, and for really good
Oh,
reasons.
undeniably. Human milk is the best source of nutrition for infants. It contains unique immune factors you just don't find in formula, which
Hmm.
leads to fewer infant infections.
Hmm.
And breastfeeding mothers themselves benefit too. There's a reduced risk of depression and certain cancers.
Mm.
The World Health Organization recommends exclusive breastfeeding for the first 6 months.
But a common and very real concern for mothers must be, do I have to stop breastfeeding if I need medication? That must feel like a huge barrier for many.
It absolutely is. It's a frequent worry. And just like in pregnancy, mothers might have chronic conditions needing ongoing management. Plus, postpartum, they often need pain relief or medication for common issues like constipation or hemorrhoids.
And what about issues directly related to breastfeeding itself?
Yeah, things can come up. Infections like mastitis might need antibiotics. For low milk supply, sometimes galactagogues drugs like domperidone or metoclopramide are used off-label to stimulate prolactin for milk production
Okay.
and postnatal depression. That affects a significant number, maybe 10–15% of women. SSRIs might be required. And what's often a huge relief for mothers to hear is that it's actually seldom necessary to stop breastfeeding if an antidepressant is needed.
That's really important. So medication for mental health can often be continued safely. That's massive support. What about contraception post-childbirth? Any specific advice there?
Yeah, the progesterone-only pill is typically preferred initially,
Mhm.
mainly due to its safety profile while breastfeeding.
Okay.
And speaking of safety, caution is definitely advised with some common over-the-counter medications. For example, pseudoephedrine, you find it in some decongestants.
Got it.
It can actually suppress milk production. And it can have systemic effects on the baby too, so it should generally be avoided. That's something many people just don't realize.
Good to know. Okay, so how do drugs actually get into breast milk from the mother's system? Can you walk us through that journey?
Sure. It's basically a multi-step process.
Mm.
First, the drug is absorbed into the mother's circulation.
Mm.
Then it diffuses across into the breast milk itself. The baby then ingests the milk, absorbs the drug from their gut, and finally, it reaches the baby's bloodstream, where it could potentially cause a clinical effect.
And how does it get from the blood to the milk?
The milk-producing cells, called lactocytes, are right next to the mother's capillaries. That close proximity allows the drug to transfer into the milk.
Okay. Now, I've heard something about breast milk being quite different right after birth. Colostrum. Does that affect drug transfer?
Absolutely, yeah. And this is where it gets really fascinating. In the first, say, 72 hours postpartum, during the colostrum period, the mammary glands are actually quite leaky.
Leaky.
Yeah, there are naturally large gaps between the lactocytes. This design is brilliant. It facilitates the easy transfer of immune cells and antibodies
Mm.
from mother to baby, giving that crucial early protection.
Right. However, it also means medications can potentially leak through more easily during this time.
Ah, okay. But
But despite this leakiness, the actual volume of colostrum is very low, maybe only about 20 milliliters per feed. So the absolute dose of drug transfer to the baby might still be quite low, even if the pathway is easier.
right, the total amount is small. So, similar to placental transfer, what factors influence how much drug makes its way into breast milk? Is it the same sort of things?
It is quite similar, yeah. The maternal plasma drug concentration is still key. Higher levels in mom's blood usually mean more in the milk.
Okay.
Molecular weight matters too. Bigger molecules find it harder to cross into milk. Oral bioavailability is also important.
How so?
Well, drugs that are poorly absorbed by the gut, like heparin or insulin, are generally better choices because even if some gets into the milk, the baby won't absorb much of it from their gut when they drink the milk.
Ah, clever. And protein binding again, still important. Yes, very important. Just like with the placenta, only the unbound, free portion of the drug can cross. So highly protein-bound drugs, like warfarin, which is about 99% bound in maternal plasma.
5%.
Yeah, very little of it actually gets into the breast milk because most of it is stuck to proteins in the mother's blood.
Okay. What else?
Lipid solubility also affects transfer. Fat-soluble drugs, like many antidepressants or CNS medications, tend to partition more easily into the fatty component of milk. And finally, the drug's degree of ionization, its charge, is important. Uncharged drugs diffuse into milk more easily. And milk pH is slightly more acidic than plasma, which can influence whether a drug becomes charged or uncharged once it's in the milk.
Okay. So if we put all those factors together, what would be the ideal drug characteristics for a breastfeeding mother? What profile are we looking for?
Ideally, you're looking for a drug that is, let's see, a large molecule, has very low or zero oral bioavailability, is highly protein-bound, has low lipid solubility, has a short half-life, so it clears quickly from the mother's system, and ideally has properties meaning it stays charged or ionized in the mother's plasma, making it less likely to cross into the milk in the first place.
Right. So beyond just the drug's properties, what other sort of holistic considerations need to be taken into account when thinking about medicine use in breastfeeding?
Oh, absolutely. You have to think broader. You absolutely need to consider the child, their age, maturity. A preterm baby is different to a full-term one, their general health, and their feeding pattern. An exclusively breastfed newborn gets way more exposure than a toddler who just nurses occasionally.
Good point. What else?
Then there's the mother, the specific medicine being used, its class, how it's given root, the dose, how long she needs it for, and her own health status like her kidney or liver function, and even genetic variations in how she metabolizes drugs can play a role.
Right.
And finally, if you consider the drug itself, specifically its inherent toxicity. Is this a drug that could be particularly harmful to an infant, even in small amounts?
Okay. And there are specific ways to try and quantify the baby's exposure, aren't there? You mentioned the milk to plasma ratio, MP, and the relative infant dose, RED. What's the difference and why does it matter?
Yeah, that's a really important distinction. The MP ratio is simply the concentration of the drug found in the milk divided by its concentration in the mother's plasma.
Uh-huh.
A ratio less than 1 is generally seen as good.
Right.
But, and here's the crucial insight, while it's useful, MP alone doesn't perfectly tell you the actual dose the infant is getting. You could have a high MP ratio, meaning the drug concentrates in milk, but if the mother's overall plasma level is very low, the baby still might not get much drug. It can be a bit misleading on its own.
Ah, okay. So that's why the relative infant dose, the RID, is more helpful. How does that work?
Exactly. RID is a much more comprehensive measure. It estimates how much of the maternal dose, adjusted for the infant's weight, the infant is actually receiving via the breast milk.
So it estimates the baby's actual dose.
Precisely. It helps determine if the exposure is likely to be clinically significant. As a kind of general rule of thumb, an RID of less than 10% is usually considered safe for most drugs.
But with caveats.
Always with caveats.
Yes.
It absolutely must be weighed against the drug's inherent toxicity, the dose the mother is taking, and the infant's age and health status. Sometimes you can even compare that estimated infant dose to known safe pediatric doses for that specific medication, which gives you a much clearer risk picture.
That makes sense. Where can healthcare professionals and the public find these kinds of specialized resources specifically for breastfeeding? Are they the same as for pregnancy?
Some overlap, but there are key specialized ones too. LactMed is excellent. It's a free web-based resource from the NIH in the US with monthly updates. Hale's Medications and Mother's Milk is another highly regarded, though subscription-based, resource. And Briggs, which we mentioned for pregnancy, covers lactation too. The New Zealand Formulary, NZF, Medicines Information Services, MedSafe here, and also the Breastfeeding Network in the UK has really good public fact sheets. Lots of places to look.
And just to give an example of that nuance again, warfarin. It's considered compatible with lactation, even though it's a small molecule, which we said usually crosses easily. Why is that okay?
That's a fantastic question, and it really highlights why simple rules don't always apply. Despite being small, warfarin is, as we said, about 99% protein bound in the mother's circulation.
Right, the binding is key.
Exactly. It means an extremely tiny fraction of the drug is actually free and available to transfer into the breast milk, so that the amount the baby gets is clinically insignificant, making it safe for breastfeeding. It just demonstrates you really need to look at the full picture of a drug's properties, not just one characteristic.
Okay. So to recap and refine then, what are the essential principles for medicine use during breastfeeding?
Right. First, basic common sense.
Hmm.
Use medicines only when absolutely necessary. If essential, use the lowest effective dose for the shortest possible duration. And maybe consider alternative routes of administration like an inhaler instead of tablets to
Yeah.
minimize infant exposure.
Good tip.
Choose drugs, if you have a choice, with short half-lives, high protein binding, low oral bioavailability, or high molecular weight. Prefer drugs with a long-established safety profile over newer ones where we have less data.
Okay.
A useful rule of thumb. If a medicine is considered safe for direct use in infants at a certain dose, it's generally going to be safe for breastfeeding mothers.
That makes sense.
Remember that RD of less than 10% is a good general guideline, but always context is key.
And this is a really critical point you made.
Yeah.
You absolutely cannot assume that a medicine deemed safe or unsafe during pregnancy will automatically have the same implications during breastfeeding.
Absolutely not. You need a separate, thorough risk assessment specifically for lactation. There are different scenarios.
Right. Are there drugs that are definite no-goes during breastfeeding?
Yes, a small number are generally contraindicated, things like chemotherapy agents, certain radioactive compounds, lithium sometimes.
Yeah.
The lists are available in those resources.
Okay. Any final practical tips?
Yeah, maybe take medication immediately after breastfeeding.
Oh.
That might help avoid the peak concentration period in the milk for some drugs. And always, always monitor the infant for any potential signs of adverse effects, unusual sleepiness, irritability, feeding problems, rashes. It really boils down to an individualized risk-benefit analysis, ideally involving a multidisciplinary team if things are complex.
Okay. Well, we've certainly navigated some intricate pathways today, looking at medication use during pregnancy and breastfeeding, from those profound physiological changes in the body to the complex ways drugs transfer and the essential resources available.
Yeah, it's a lot to take in. But the goal of this deep dive wasn't really to overwhelm you, hopefully, but more to empower you with the knowledge that informed choices are possible. Understanding the why behind the guidelines, allows you to engage much more meaningfully with your healthcare providers and advocate for the best outcomes for you and your baby.
Right. It's all about balancing that necessary treatment with minimizing potential risks, isn't it? Always prioritizing the well-being of both.
Exactly. Well said.
So here's a final thought to leave you with. As we've seen, so much of our knowledge about drugs in pregnancy and breastfeeding comes from careful, real-world observation, from post-market surveillance rather than direct clinical trials, because pregnant and breastfeeding people are often excluded.
That's true.
How might a deeper understanding of all this, the pharmacokinetics, the risks, the benefits, how might that empower us, not just as patients making choices today, but perhaps as advocates for more inclusive, more ethical drug research in these vulnerable populations in the future, to ensure that generations to come have even clearer, more direct evidence to guide their choices?
That's a really powerful question to end on. Something definitely worth thinking about.